Hi guys, thank you for joining us on Prague ICU. Our today's presentation is dedicated to midline insertion, in which we will give you more useful tips and tricks on the topic. Midlines are non-tunneled peripheral lines, which are inserted through a peripheral vein in the arm, basilic, brachial or cephalic vein. Usual dwell time is 14 days, but a midline can last up to 30 days in certain circumstances. Midlines have a single or double lumen, and are 3 to 5 French in diameter. They are usually 7.5 to 25 cm long, and the tip is not terminated centrally in the superior vena cava, but it typically terminates at the axillary vein or below. Therefore, a follow-up chest X-ray is not required to confirm catheter placement, although this might be useful for difficult insertions. As previously noted, there exist different types of midlines, 1 or 2 lumen, shorter or longer ones. Indications for midlines are need for 1 or more weeks of IV therapy suitable for peripheral delivery, e.g. antibiotics, need for vasopressor or inotropic therapy, or we use them in patients with difficult periphery access. Contraindications for midlines are total parenteral nutrition, solutions or medications with pH less than 5 and above 9, and those with high osmolarity, vesican chemotherapeutic agents, mastectomy or fistula on site of insertion, requirement for line to be used for blood sampling, or if we need to administer blood products. In contrast, PICC lines are indicated for total parenteral nutrition, infusates with extreme variations of pH, administration of vesican drugs, extended duration of intravenous therapy, or if frequent blood draws are required. There are 3 veins to choose from: basilic, brachial or cephalic. So, which vein to target? Basilic vein. It's not usually the biggest, but often the easiest one. Brachial vein. Not the easiest, but often the biggest. And cephalic vein is our last option. Before the procedure, perform bilateral ultrasound scan of all veins at arm, choose the appropriate vein and midarm, clearly identify the median nerve and brachial artery. This is the typical transversal ultrasound view with compression. On the left side, we can see the brachial artery, non-compressible structure. Below is the brachial vein, compressible structure. On the right side of the artery and vein is situated brachial nerve, the honeycomb structure, always avoided during insertion. And on the right side, you can see the basilic vein, again, easily compressible, usually our main target for midline insertion. This is the typical transversal ultrasound view with color Doppler, again, with brachial vessels on the left and basilic vein on the right. We need to be aware of 3 zones of an upper arm. We should stick in the catheter within the green zone, middle part, and our catheter should terminate at or below axillary vein, definitely before junction between axillary and subclavian veins. Among complications of the procedure belong arterial puncture, nerve injury, pain, unsuccessful insertion, bleeding or bruises, and loss of guide wire. With regards to arterial puncture, the most important is the prevention, good ultrasound technique, vessel assessment, and puncture site selection. If you are unlucky and hit the artery, do not panic and apply compression. To prevent nerve injury, go preferably for a basilic vein. This is the first recommendation. If you go for brachial vein, identify the nerve and avoid it. It is the honeycomb structure. If the patient reports paresthesia, stop. Post-procedure complications include entry site infection, bloodstream infection, phlebitis, occlusion, persistent withdrawal occlusion, loss of line or air embolism. Regarding entry site infection, prevention is much better than cure. Line doesn't always have to come out. We can use the chlorhexidine sponge, biopatch, to decrease the probability of infection. Phlebitis is related to chemical irritation caused by the medication. It is often followed by occlusion of the vein, hence check the vesicant list before application. Just because the line doesn't bleed back doesn't mean it's blocked. It is frequently the result of inadequate flushing. Apply 20 ml saline using a push-pause flush technique. Definitely, you can use urokinase to unblock it. Thank you for watching Prague ICU and stay tuned for more interesting intensive care stuff.